Hi, this is Elliot Fishman, and welcome to January 2020. Another year, another great year for CTSS, and hope all of you enjoyed your New Year's vacation, but it's January 1st, and so we have 10 terrific cases. Let's see how much smarter you are in 2020 than you were in 2019. So 10 great cases. Let's get started. In this first case, the patient's pancreatic cancer, and I ask you, what's the best diagnosis in the liver? When you look at the liver, coronal and sagittal, you see this low density, which at first looks like artifact. You realize it's very sharply marginated. That's not recurrent tumor. Tumor recurrence does not look like that. Infarctions are peripheral and wedge shape, so you can think about that, but this is not peripheral and wedge shape. It's not an abscess. This patient had radiation therapy, had a wide port, and you can see the radiation changes. Now, the radiation changes, typically low density in the liver. You can see some prominent blood vessels, but typically no bleeding. But just a very nice example, and not to confuse this with tumor recurrence. Now, these days, with better radiation therapy, without the high doses, with the multiple ports, radiation-related injury is much less common. This patient also has pancreatic cancer. And what's the best diagnosis? What I'm trying to show in this case, I was giving a lecture the other day about fatty liver and the problems with fatty liver, that it can easily hide mets. Now, in this case, you see multiple nodules in a patient with pancreatic cancer, and this was multiple metastasis. Now, with fatty liver, you could consider regenerating nodules, particularly if you had bug Chiari, but the appearance is different. This is not cirrhosis, it's fatty infiltration of the liver. And this could be metastasis, and it is metastasis, but I wanted metastasis in a fatty liver. That's the best answer, and that's the correct answer. I also read a bit about the tumor that occurs typically in fatty liver is going to be hepatic adenoma. They're often multiple. The best diagnosis in this case is, well, what do we see? We see a mass in the mesentery to right of midline. The mass is hypervascular. There's desmoplastic reaction. Do I need to say anything but carcinoid tumor? Lymphoma gives mesenteric masses, but the coronals really show you the desmoplastic reaction. Sclerosing mesenteritis is a mass in the mesentery, commonly calcified, but does not have this desmoplastic reaction. So this is not sclerosing mesenteritis. In this patient with Chiari Syndrome, what are the liver nodules? You see multiple hepatic nodules, and of course you could say maybe it's multifocal hepatoma. Maybe the patient has immunosuppression, and maybe they have lymphoma. And maybe, just maybe, coincidentally, they have FNH. But the real answer is regenerating nodules. It's very common to get regenerating nodules in Chiari Syndrome. They're often multiple. They can be confused with hepatoma. They stay vascular on venous phase, and also if you compare the size from arterial to venous phase, it often will get bigger. So this was regenerating nodules in Chiari Syndrome, an important finding. Now, in this case, I ask, what's the best diagnosis? What you see on these coronal views, image on your left, you see thrombus in the portal vein and SMV. You then see thickened bowel with really what looks like a halo diffuse edema. There's no obstruction, so it's not like a midgut volvulus, but what you're looking at is SVC, portal vein occlusion, and this patient's diseased bowel. This is not the appearance of Crohn's or GVA, so lymphoma. You can see parts of it in Crohn's and GVH, but the classic thing here is ischemic bowel. You've occluded the portal vein and SMV. You have thickening with a halo effect and this little ribboning on the right in the patient's bowel. Very nice example of small bowel ischemia. This patient was an IV drug abuser, had left groin pain. What do you see? Well, you see how it's enhancing, and by the way, on the image on the left, you see several needles in the right inguinal zone for this drug addict. You could consider an abscess. They thought that was the case on the palpation. Could it be lymphoma? There's some mass effect. Could it be carcinoid? But what we're just seeing here is when you give IV contrast, this is a large bilobe pseudoaneurysm. That indeed is impressive. Pseudoaneurysms very commonly due to venous puncture, not uncommon in IV drug addicts in many locations. Just a really good example. The best diagnosis in this patient, what do we see here? We see a number of different things. You see the peripheral decreased enhancement, sort of a flip-flop, centrally increased enhancement, peripherally decreased enhancement. There's some increased vascularity toward the dome. The patient does have cirrhosis, that part's true, but that does not have liver mets and does not have hepatoma. This is a really good example of a patient with bug Chiari. And what this patient has then is regenerating nodules. Now, regenerating nodules are best seen at times on arterial phase imaging, though here I gave you venous phase. You can see them as well, but you can see the changes, the lack of hepatic veins for the most part, the flip-flop enhancement. Very nice example. What's the most likely finding in this case? Well, when you look, there's several findings. One is there's vascular liver mets, or vascular liver lesions. Then there's a mass in the body of the pancreas. So maybe it's a neuroendocrine metastatic to pancreas. That's a good thought. It's not going to be lymphoma, not going to be lung cancer. But then you look and you say, wait, there's clips where the left kidney should be. There is no left kidney. So this is metastatic renal cell carcinoma to liver and to kidney. A very classic case. Remember how we talk about you're going to miss these tumors unless you give IV contrast, and you're often going to miss them because they're small. Now in this case, we have a pancreatic mass, and I asked you what's the best diagnosis in a middle-aged female. Complex, cystic, and solid. If this was this 18-year-old, SPEN tumor is the answer. Could this be neuroendocrine? It can be. You could think about it. Neuroendocrines can be cystic. They're usually with rim enhancement. IPMNs, it's not going to be an IPMN because there's solid components, septations, enhancement of the septi. If this was an IPMN, you would have had to say it had malignant degeneration. But this is neither. This is a serous cystadenoma, common benign lesion, most common head of pancreas, nodularity, septations, displacement of vessels, and a very good article by Linda Chu on this topic just about a year ago. This patient was found down, and I am asking what statement is true. If you look at the images, you see fluid in the abdomen, which is blood, but the key finding is look at the adrenal glands on axial and coronal. That adrenal is bright. The patient is hypotensive. So the patient had a recent MI. I can't tell you that, but it could be. The patient was in an MVA. You see free fluid in the abdomen. It could be. The patient had intracranial bleed. I guess maybe. But the key thing you can say 100%, when you see normal-sized, very bright adrenals, regardless, that patient is hypotensive, you better call the patient's physician. Sometimes they know, but many times they don't know. So it can be a real lifesaver, and you can see it very nicely. So those are my 10 terrific cases for the month of January. Hope you enjoyed them. Hopefully you got them all right, or at least some of them right. And with that, I wish you a great day and speak to you tomorrow. Bye.
Great.
Okay?
So we have a mistake?
Yeah. So just go to number 7.
Okay, just let me save this real quick. We're gonna... If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the February 2020 CTisus quiz. We're into February. The winter is almost over. Let's look at 10 terrific cases. In this first case, I asked you what is the least likely diagnosis. When you look at the images, you see a large anterior mediastinal mass which appears to infiltrate around the vessels, particularly the left innominate vessel. There is maybe some enhancement present, but probably some calcification. What could this be? Teratoma is going to be, when you think about anterior mediastinal masses, teratoma, thymoma, thyroid, lymphoma, we think about. So teratoma, which in fact is the answer in this case, is definitely a possibility. Lymphoma, again, in terms of calcification, usually lymphoma calcifies with treatment, but large masses, nodes, infiltration, lymphoma is good. Metastatic renal cell, you can get mets to the mediastinum, typically it's the hilar regions, so that's a possibility. Sarcoid. Sarcoid gives you nodes in the paratracheal, in the hilar, and the subcarinal region. You don't typically get anterior mediastinal nodes. When you have nodes, you have discrete nodes that you could draw lines around, not an infiltrating process. So the least likely diagnosis is sarcoid, and as I mentioned, this in fact was a teratoma. In this case, I'm asking what's the most likely diagnosis. On the axial images, you see a mass in the patient's right atrium, and when you look at the coronal, you can see it's coming from below the diaphragm. Now, this is not flow-related changes. You can get primary IVC sarcomas, but they're usually lower, they're more vascular, and they're more mass-like. This looks like it's something that's coming from the liver. Okay, well, things that come from the liver or from down below, you think of adrenal carcinoma, you think of hepatoma, you think of renal cell carcinoma. This was the only choice you have, hepatoma. So not an IVC sarcoma, it's not an angiosarcoma of the heart, which begins in the wall, typically of the right atrium or right ventricle. This was a hepatoma. Just a very, very nice example of that case. The most likely diagnosis in this case is, when you look at the coronals and then the cinematic rendering, there's a cystic lesion to the left of midline. It displaces bowel. Lymphoma is not cystic. An abscess can be cystic, but usually this is so well defined. This is water density. This is cystic. Carcinoids are in the mesentery. They enhance, they calcify. You have a desmoplastic reaction. Water density, well defined, it's a cyst, and the best diagnosis in this case is a mesenteric cyst. The best diagnosis in this case is, what you see here is a nodule in the left lower lung, and you realize it's enhancing, and then when you look at the MIP, you can see it's coming off the patient's pulmonary artery. This is not a lung met. I guess occasionally mets from renal cell will be vascular. This is not a hamartoma. They usually are calcified and contain fat and a low density. It's kind of smooth for primary lung cancer, and they don't enhance like this. And then the beautiful vessel going to it. This was a nice example of a pulmonary artery aneurysm simulating a lung nodule. A very nice case. The best diagnosis in this case is, this case I want to show you because this was misread originally. Of course, it was an outside hospital. If you look at this case, what do you see? It looks like an enhancing lesion by the tail of the pancreas. If you thought it was pancreas, then you might say neuroendocrine, or you might say a metastatic renal cell to the pancreas. Adenocarcinoma, you're not going to say because that's hypovascular. But when you look carefully, this is really coming off the splenic artery. This is splenic artery aneurysm. And I have seen and been shown a few cases of splenic artery aneurysms that were called neuroendocrine tumors. So you would need to be very, very careful. This is a great case, and I asked you what the least likely diagnosis is. Well, let's look at the images. We see a mass infiltrating the mesentery. It looks like it encases the vessels. There's some neovascularity and maybe some calcification. Well, if you ask me what the best diagnosis here, I would say probably sclerosing mesenteritis, which indeed this was. You could think about a carcinoid. Usually they're more calcified. The vessels look a little bit different and stretched, but it could be a carcinoid. Lymphoma can infiltrate the mesentery, but usually it's more like a sandwich sign. It's not so vascular, but it could be. But the one thing this is not is pancreatitis. Pancreatitis can extend down into the mesentery. You could see displacement of vessels, but the inflammation of pancreatitis looks different. This is more solid. This, in fact, as I mentioned, was sclerosing mesenteritis, and the least likely diagnosis would be pancreatitis. The least likely diagnosis in this case is, well, the cystic lesion, tail of pancreas with calcification. It could be a cystic neuroendocrine tumor, and they commonly calcify, and in fact, that's what it was. In a young patient, it can be a SPEN because they can be cystic and they have dense calcification. Mucinous cystic neoplasms have rim-like calcification. They're cystic. They can be in the body, less likely toward the tail. So it's not that likely to be as MCN. That would not be my differential at the top. But the one thing this is not is an adenocarcinoma. It's cystic, dense calcifications. Adenocarcinomas essentially never calcify. So the least likely diagnosis is an adenocarcinoma. The best diagnosis in this middle-aged female is, well, what do I see? I see a large kind of cystic pancreatic mass with dense central calcification. There's no common duct dilatation to speak of. If this was a young patient, it could be a SPEN. Neuroendocrine tumors commonly calcify, but the calcifications are often more dystrophic. It usually enhances more and is not so smooth, but it can be. And MCN can calcify, but it's cystic and in the body. The age is good, middle-aged female. But this is more classic. If you look hard, particularly the image on your right, it looks cystic, it looks like septations, and it looks like there's calcifications present. And this is just a really good example of a serous adenoma. The best diagnosis in this case is, well, you see the liver. At first glance, you think of fatty infiltration, but you realize the low densities in the periphery. There's lots of ascites. The spleen is big, and you're not seeing the hepatic veins. This is not a pattern of metastasis, and it's not a pattern of infiltration by lymphoma. This flip-flop phenomena is classic for Budd-Chiari syndrome, and this is a beautiful example of Budd-Chiari syndrome. Again, the lack of the hepatic veins, the narrowing of the IVC, all help you make the diagnosis. The most likely diagnosis in this case is, well, what do you see? You see narrowing of the patient's left subclavian artery. You look at the 3D, it's beautifully narrowed. So you can say atherosclerosis, but the vessels all look good. It's not atherosclerosis, and that's not a great distribution to have just non-calcified plaque. Ehlers-Danlos gives you aneurysms typically, though it does give you strictures as well. Not a great location. Kawasaki's, think of coronary arteries, but Takayasu's, thickening of the vessel wall. The most common vessel involved is the left subclavian, and you have your diagnosis, Takayasu's aortitis. Anyway, those are 10 terrific cases. I hope you enjoyed them. I hope you learned something, and I hope you have a great month. And we'll see you next month. Ciao, ciao, ciao. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to our March 2020 CTSS quiz. It's hard to believe it's March already, but so far so good on the weather. Get past February, life is good. No snow. I'm sure we'll get a snow in March. That's my prediction, because we always do, but it'll melt away in a day. Anyway, we have 10 terrific, most outstanding, most incredible cases for you. So without further ado, drum roll please, da-da-da-da, let's get started. In this patient with unexplained abdominal pain, the best diagnosis is, and so when you look at these images, the axial and the coronal, the key finding is look at the left renal vein. There's non-occlusive thrombus in the left renal vein. There's a subtle difference on the axials between the function of the right and left kidney, and the left kidney is a little bit enlarged. I don't see a mass, so it's not a renal cell carcinoma. Obviously, carcinomas invade into the renal vein, or they can. There's no renal artery aneurysm, and I don't see the left gonadal vein at all, or I do see it. But the key finding is the non-occlusive thrombus in the left renal vein. Renal vein thrombosis can be due to tumors, hypocoagulability states, dehydration, vasculitis, and on. Just a very nice example. In this case, I asked you what the best diagnosis is, and this is something I wanted to write up because I once made this mistake. If you look quickly at the images, you see what appears to be a mass coming off the stomach. You can see it very nicely on the cinematic as well, but if you look back on the images, you can see the peripheral enhancement. And if you look carefully, this was not a gastric mass, but this was a hemangioma arising off the left lobe of the liver, pushing against the stomach. And it's a great example of hepatic hemangioma. I've seen this case mistakenly called a gastric tumor. I've seen it being called a pancreatic tumor, a retroperitoneal sarcoma. Again, what helps me out just on the couple images I gave you is the rim enhancement, that classic puddling that you see with hemangiomas. The best diagnosis in this patient with hematuria is the first thing you notice is an obvious right renal mass, and your first thing is to say, oh my goodness, am I dealing with papillary or clear cell renal cell carcinoma? It doesn't have the appearance of an abscess. Abscess is a low density. There's usually perirenal stranding. There's perfusion changes. But then you look carefully, and unfortunately I didn't give you a cursor here, but a big component of the tumor is the same as the retroperitoneal fat, and this was an angiomyolipoma of the kidney. Angiomyolipomas, particularly when they're fat poor, can be difficult to distinguish from classic renal cell carcinomas. You can ask the question, well, I once heard of a patient who had a renal cell with fat in it, but typically those are large clear cells with invading of the perirenal fat. This is well-defined, exophytic, a renal angiomyolipoma. Just a very nice example. This patient had hypertension, and we were asked to look at the renal arteries. You can see the cinematic rendering in the MIP, and in both examples you see high-grade stenoses of both renal arteries. This is not FMD, where you see more of a beating appearance or occasionally aneurysms or areas of narrowing. It's not a dissection, and it's not an aneurysm. This is a classic example of bilateral renal artery stenosis. Again, the MIP imaging or the cinematic or volume rendering in general is very good at showing these findings. This patient has hypertension, and what's the best diagnosis? If you look at the left renal artery, you see beating. If you look at the right renal artery, you see beating, and there's also aneurysmal dilatation right by the hilum of the right kidney. The aorta shows minimal plaque. This is not renal artery stenosis. This is not a dissection. And yes, there's aneurysmal dilatation of the right renal artery, but the key finding is the beating with the dilatation. Beautiful example on MIP and cinematic rendering of fibromuscular dysplasia, or FMD. The least likely diagnosis in this case of an incidental adrenal lesion is, well, typically when you look at a lesion, it's an incidental finding under 4 cm, it's almost always an adenoma. Pheochromocytomas can also be presenting. More pheos present incidentally than as hypertension. And in fact, this case eventually was proven to be a pheochromocytoma. This is not the appearance of adrenal hemorrhage. Now, if primary adrenal carcinoma, if you pick up a small carcinoma, it's usually because the patient is hyperfunctioning. If the patient is not hyperfunctioning, and typically Cushing's is the problem, then you're going to pick up a large mass. So the likelihood of picking up an incidental adrenal carcinoma under 4 or 5, or truthfully under 10 centimeters is very rare. And this was an incidental pheo, and the least likely diagnosis was number C, a primary adrenal carcinoma. The most likely diagnosis in this 30-ish-year-old female is, you see a vascular lesion on arterial phase imaging. It's vascular, but only as bright as the IVC. It's not as bright as the aorta. And then on venous phase imaging, it's nearly gone, though of course you can kind of see where it is. Hepatomas can become isodense, including fibrolamellar. Hemangiomas can become isodense, but peripheral puddling and central filling in is the classic thing. Hepatomas and fibrolamellars are typically not so homogeneous, and they're also markedly vascular. This is a classic non-cirrhotic liver, homogeneous enhancement mass, which becomes near isodense quickly, of focal nodular hyperplasia. The most likely diagnosis in this 60-ish-year-old female is, and this is a very nice case because you have 2 findings. One is widespread blastic bone metastasis. The other is ascites, but more important, the advent beyond the ascites is a diffuse gastric wall thickening in the appearance of linitis plastica. Lymphoma can give you bulky tumor, rarely giving you sclerotic bone lesions. Adenocarcinoma can give bone lesions, but not the extent of this. Breast cancer is the one that gives you widespread saturated blastic bone mets, as well as gastric metastasis from linitis plastica, carcinoid tumor, vascular lesions, not this appearance. This is a classic breast cancer with linitis plastica, carcinomatosis, and widespread bony metastasis. A very nice example. The best diagnosis in this 20-ish-year-old female is, well, you see a large, and actually it's multicentric, hypervascular mass in the liver, nicely shown on the cinematic. Could this be metastatic carcinoid? Sure, but 20-year-old female, unlikely. Renal cell, unless you have von Hippel-Lindau, unlikely. Hepatoblastoma, vascular liver lesion, sure, but the patient's a bit old. Hepatoblastomas are under age 10. The best diagnosis, young female, irregular, aggressive-looking liver mass, hypervascular, is a fibrolamellar hepatoma, and that was the answer in this case. In this patient, status post-partial nephrectomy for renal cell cancer, what's the best diagnosis? And you look carefully and you say, what's going on in the left kidney? You can see the zone of partial nephrectomy, but you see a bright enhancing structure. That's a pseudoaneurysm. One of the complications of partial nephrectomy is pseudoaneurysm. There's no differential. If you didn't have contrast, you would just see stranding and you might think there was a bleed present or postoperative change. You do have perfusion changes, but it's not an abscess. It's not local recurrence. This is renal artery pseudoaneurysm. One of the reasons we want to do arterial phase imaging on follow-up studies is to look for vascular complications, and renal artery pseudoaneurysm is the one on top of my list. Anyway, those were 10 cases. I hope you got them all right. I hope you learned something, and I hope to see you soon on CT is Us. Have a great day. Bye.
Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to April 2020 CTSS quiz. April means Easter, and it means Passover, and it means springtime, so hopefully we will see that. So let's look at 10 absolutely terrific cases. In this first case, I asked you for the best diagnosis for the left renal mass. If you look at the left kidney, you can see that it's infiltrated, but the process may also involve the tail of the pancreas. It extends into the aorta, it extends into peri and pararenal space. It's best defined as infiltrating the kidney, particularly toward the upper pole. This is not the appearance of a papillary or clear cell renal cell carcinoma, which can extend beyond the kidney, but not this infiltrating pattern. Renal abscesses are usually cystic, low density, and they can extend into the peri and pararenal space, but this is best defined as an infiltrating process. And the best diagnosis, therefore, is lymphoma. Lymphoma of the kidney can present as a solid mass, but also can present as an infiltrating process, and that's very nicely shown in this example. This patient had a history of von Hippel-Lindau disease, by family history, that is. And what's the best diagnosis? Well, when you look at the coronal views and the 3D views, you see bilateral adrenal masses, which are vascular. So we know it's something that's bilateral. You can have bilateral adrenal hyperplasia, but this does not look like hyperplasia. This looks like masses. You could have adenomas, but these lesions are enhancing like the kidneys. They're vascular. Bilateral adrenal carcinomas occur in about 1% of cases, but then usually the primary one is going to be very large and one may be a bit smaller. These are relatively the same size and relatively small. And von Hippel-Lindau patients have an increased incidence of pheochromocytomas and an increased incidence of bilateral pheochromocytomas, and that's what it was. Remember, if you can't remember, Pheo's the rule of 10. 10% are syndromic, 10% are bilateral, and 10% are malignant. These are bilateral adrenal pheochromocytomas. In this case, I asked for the least likely diagnosis. What do you see on the coronal and on the cinematic? You see an infiltrating process that has calcifications encasing the vessels, particularly on the venous side. It's infiltrating into the mesentery. Now, it is true lymphoma rarely calcifies unless it's been treated, but maybe it's treated lymphoma, which recurred or is still present. Sclerosing mesenteritis is a great diagnosis, infiltrating process, calcifications, and carcinoid is also a great diagnosis, infiltrating. Carcinoids, often you see a small bowel tumor and then you see a mass in the mesentery. This is really the root of the mesentery. I guess it could be carcinoid, But carcinoid sclerosing mesenteritis are definite possibilities. In fact, this ends up being sclerosing mesenteritis, mass, infiltration, and calcification. Now, what this is not is mesenteric pediculitis. That's mass-like, it's low density, it's fat density, it's swirling, it's not solid, and it doesn't involve the vessels like this. So the least likely diagnosis is mesenteric pediculitis. If I asked you for the most likely diagnosis, I would have said sclerosing mesenteritis. The most likely diagnosis in this case, this is a beautiful case, very impressive. Something's infiltrating the left kidney. There's also extensive tumor in the paraortic and in the mesenteric region, and also extending by the right kidney and down by the psoas on the left side. Testicular tumor can give large masses, but typically they obstruct the kidney and they're often cystic. TB can infiltrate with nodes, but in the kidney it tends to be calcification. In a shrunken kidney, TB just doesn't look like this. Retroperitoneal fibrosis is infiltrating and can cause obstruction of the kidneys and can infiltrate into the kidneys, but this is so mass-like. When you look at the coronals, look at the extent from diaphragm down into pelvis, and this is a great example of lymphoma. This was B-cell lymphoma, extensive adenopathy, extensive infiltration, and involvement of the left kidney. Very nice example. The most likely diagnosis in this 60-year-old patient, what you see is a cystic lesion involving the body and tail of the pancreas, and if you look toward the tail, there's calcifications present. It's not going to be a pseudocyst like post-pancreatitis because you don't get calcifications. You're going to have punctate calcifications with chronic pancreatitis, but this is more of a dystrophic appearance of the calcification. MCNs are typically in the body of the pancreas. It would be very large for an MCN, not a great location. Adenocarcinomas can be necrotic, but this is really cystic. And the best diagnosis in this case is a serocystenomas. Serocystenomas have calcification. Often the calcification is centrally, but not necessarily the case. So this was a serocystenomas. Excellent case. The most likely diagnosis in this case, you see evidence of about a 7-centimeter mass, and then the first question is, where is it? It's somewhat vascular, and perhaps it's coming from the pancreas, though one would admit when you look at the coronal view, it looks like it's coming off the fourth portion of the duodenum, but it does abut the pancreas. It could be a GIST tumor, I have to admit. GIST can occasionally be vascular, particularly when they're small, but this is a bit large. Lymphoma, exophytic lymphoma, it's too well defined for me. A neuroendocrine tumor of the pancreas is a consideration, but I think this is arising from the duodenum and not the pancreas. And in fact, this is a tough case. This ended up being a neuroendocrine tumor of the duodenum, primary neuroendocrine. Again, a GIST tumor would have been a good thought because GIST tumors tend to be more exophytic. And I've made the point in the lecture that the way I differentiate at times GIST from carcinoid is that carcinoids are intraluminal and GISTs are extraluminal. But hey, this was a neuroendocrine tumor primary in the duodenum. Just a terrific, terrific example. This patient had fever, and what was the most likely diagnosis? You see a large splenic lesion, and I have to admit, when you see that alone, I'm saying B-cell lymphoma. Yes, it could be a sarcoma. Yes, you can consider abscess. And then you notice the extensive nodes in the peripancreatic region in the paraortic zone. That's going to be lymphoma, which this was. TB can give you nodes, can give you splenic involvement, but not a big dominant mass. Angiosarcomas are typically more vascular, and the nodes are also vascular, and you commonly have liver involvement. And a splenic abscess, you're just not going to see a splenic abscess with such extensive adenopathy. And this was a B-cell lymphoma as well. The best diagnosis for the left renal mass in this case, I'm showing you two coronal views. From the non-contrast, you should say it's a high-density renal cyst. And I show this case to make the point that if you only had the contrast scan, you would wonder what the lesion is. Perhaps it is a papillary renal cell carcinoma. Lymphoma would be unusual. It's not an angiomyolipoma. I see no fat. But once you have the non-contrast, it's very easy to make the right diagnosis, which is a high-density renal cyst. The most likely diagnosis in this patient with right upper quadrant pain. When you look at the axials, you see a mass with some high density but a lot of fat. And you look at the coronal view, you can see this mass is pushing the right kidney down. Well, what is it? It could be a liposarcoma, but it looks well defined, though I have to admit you would consider a liposarcoma. Mesenteric infarction, the patient didn't have recent surgery. It's almost too much fat and it doesn't have that same appearance of an infarct. The truth is the high density probably is a bleed. I'm not sure it's acute, but it's in an adrenal myelolipoma. And this is a wonderful case of a very large adrenal myelolipoma, which may have previously bled. In all likelihood it did, which is the high density, but also showing you the size. And in our lectures on myelolipomas, we do make the point that at times it can be tricky to differentiate a myelolipoma from a liposarcoma. Liposarcomas are more infiltrating, and there's many things you would see different, but sometimes it can look very similar. This patient is going to get surgery, and this was a benign adrenal myelolipoma. The least likely diagnosis in this case is, well, I'm showing you arterial phase imaging of a mass in the liver with peripheral rim enhancement. Now, this could be a necrotic hepatoma. The patient has fatty infiltration of the liver. Maybe the patient has NASH. That's a good thought. Could this be a metastatic neuroendocrine tumor? Absolutely. Neuroendocrine tumors can be vascular. They're also typically vascular, but they also can be necrotic. Could this be a primary neuroendocrine tumor? Most of the time we see metastasis, but in fact, it is a possibility neuroendocrine tumors can be very vascular with central necrosis. What this is not, however, is a hemangioma. Yes, the lesion has peripheral enhancement, but with hemangiomas and arterial phase imaging, there's peripheral puddling. When you see the entire rim enhancing and the rim is over a centimeter in thickness and it's homogeneous, that is not a hemangioma. That's going to be a malignancy. So I would have considered necrotic hepatoma. I would consider metastasis. This was unusual. It was a primary neuroendocrine tumor of the liver. Even the pathologist said, that's unusual, and I would look for a primary, but we found no others, and this is carried as a primary tumor. So with that, I've done 10 terrific cases. I hope you enjoyed them. I hope you got them right, and I hope you learned something. And hopefully I'll see you next month. Have a great day. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the May 2020 CTisus quiz. I have 10 terrific cases for you, so without any further ado, let's get started. On this first case, what's the least likely diagnosis? Well, what you see is you see a mass in the tail of the pancreas, or what looks like a mass, that's hypodense on arterial phase and then becomes isodense. Well, that's a very good description for a autoimmune pancreatitis, so that's the correct answer. Adenocarcinoma occasionally can become less visible on venous phase, but that's pretty rare. Lymphoma tends to be bulky, again pretty rare. Neuroendocrine tumor typically is hypervascular on at least one of the phases. So I'm going to say the least likely diagnosis is neuroendocrine tumor, but the correct answer was autoimmune pancreatitis. So just a very important thing to think about. In this case, the best diagnosis, what do you see? You see a dilated esophagus, lots of material within the esophagus is obstructed. I don't see a mass for esophageal cancer, and with esophageal cancer, usually it's not this much food around because the patient hasn't been able to eat for a while. It's not esophagitis, and it's surely not lymphoma. This is a beautiful example of the appearance of achalasia. Middle-aged female cystic pancreatic mass. The reality is if you only look at the mass, it could be IPMN, MCN, Serocystenomas, and pseudocyst. But if you say middle-aged female and you put the mass in the body of the pancreas, to me it's an MCN. And in fact, this was an MCN. There's also a faint calcification, which is seen not uncommonly with MCNs. The most likely diagnosis in this case. Now we have a cystic pancreatic mass with nodularity and calcification. IPMN, if this was an IPM, it would be malignancy within the IPMN. Cystic neoplasm MCN, again, it will be malignancy within it, but usually it's not in the tail of the pancreas, it's body. And this is not the appearance of an adenocarcinoma. This was a Serocystadenoma. This was resected because you really have to worry about the possibility of a cystic lesion with malignant degeneration, and it just makes the point once again that Serocystadenomas have so many variable appearances. The most likely diagnosis in this case: 6 centimeter hypervascular mass near the pancreatic head, no common or pancreatic duct dilatation, marked vascularity. I see both kidneys, so it's not metastatic renal cell. It's not the appearance of an AV malformation. And carcinoid tumors would be in the small bowel. They're typically smaller. This is a great location for a paraganglioma, which essentially is an extraadrenal pheochromocytoma, most common location organ of Zuckerkandl, but we've seen a number of them in the peripancreatic region. Elderly female with fever, the most likely diagnosis. At first glance, you see what looks almost like a fish in the right side of the abdomen, and then you're first going to think this looks like pneumatosis. Then you realize when you look at all the images, it's the kidney, it's not the bowel, so it's not diverticulitis, and it's not pneumatosis, and it's not bowel obstructed. This was emphysematous pyelonephritis, just a beautiful example of that entity. The most likely diagnosis in this case: big spleen and sclerotic changes involving all the vertebral bodies. The height of vertebral bodies is maintained, but the texture is abnormal. This is not sickle cell. That's usually bone and bone appearance. Renal osteodystrophy. Here you see normal kidneys. You wouldn't get a big spleen, and the bony changes aren't renal osteodystrophy. Lymphoma can give you sclerotic bone lesions and a big spleen, but to have diffuse involvement of the bone is not going to happen. This was a case of beta thalassemia. Now, sickle cell disease we think about, but sicklers, remember, also have a small spleen with autosplenectomy. Vertebral bodies look different. Fish mouth vertebral bodies are classic. Beta thalassemia, big spleen, extramedullary hematopoiesis. In fact, this patient had a splenectomy, and this spleen was infiltrated by extramedullary hematopoiesis, and the bony changes are excellent for thalassemia. This is a difficult case. Abdominal pain. You see a mass near the pancreas, but separate from the pancreas and inseparable from the IVC. I guess it could be lymphoma. Occasionally you have masses like this for lymphoma. Neuroendocrine tumor, it's not vascular, so unlikely. And this really is away from the duodenum. It's not a duplication cyst. So what could it be? I did consider all sorts of malignancies. Lymphoma is a good thought. This was a leiomyosarcoma. Then you would wonder, could this be a primary leiomyosarcoma, which arises from the IVC? But at surgery, the IVC margins were intact, and this was simply read as a retroperitoneal leiomyosarcoma. Just a very atypical case. 80-year-old with right lower quadrant pain. What do we see? Markedly thickened small bowel, misty mesentery. This is enteritis. And when you look at it and you look at the vessels are a bit tapering, this is ischemic bowel. It's not an adenocarcinoma, it's not bulky, it's not Crohn's disease because of the way the misty mesentery looks. You don't see the vasa recta. And sprue usually is jejunum and thickened folds. This was ischemic colitis, and at surgery, 30 centimeters of bowel was indeed resected. The least likely diagnosis in this case is the question, well, what do you see? You see a 7 centimeter mass in the right adrenal gland. This ended up being a carcinoma. Okay, that's what it was. Pheochromocytomas may not be vascular, but they usually are. Adenomas usually are hypodense, and this is large. Above 4 cm, we do see adenomas, but I would not be calling it. And lymphoma is possible, but primary lymphoma usually is bilateral, and it maintains the adrenal shape. So to me, the most likely diagnosis is an adrenal cortical carcinoma. So there were 10 wonderful cases. I hope you got that right. If not, I hope you learned something, and we'll see you next month.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the June CT is Us quiz. We have 10 terrific cases for you. So with that, let's get started. Now, in this first case, I'm asking you what the least likely diagnosis is. Incidental adrenal mass. When you look at the non-contrast, there's calcification, and I could be certain there is some fat present. But then you look with enhancement, there's some vascularity, and yes, there's hemangioma sitting within the spleen, within the liver rather. But what is it? Well, okay, myelolipoma is my first guess. Primary adrenal carcinoma? I guess it could be only based on size, but I don't think so. An adrenal adenoma? Gosh, this is big, and I don't know, some enhancement? I would say no. Pheochromocytoma? Sometimes we have big pheos that are not vascular. So I would say the least likely diagnosis was an adenoma. This patient had surgery. This was an adrenal adenoma. Again, I just want to make the point that sometimes adrenal adenomas are large and they don't look like adrenal adenomas, so you're just not going to be right. The most likely diagnosis in this case, beautiful case. What you see are coronary artery aneurysms, right coronary and left coronary artery. What gives you multiple coronary artery aneurysms? Well, if I told you the patient was a teenager, very simple, it's Kawasaki's disease. Multiple aneurysms, and you can see that in a 1 or 2 year old as well. But again, and these can easily balloon out and they can rupture. So these patients, as in this patient, will have surgical resection. The most likely diagnosis in this case, I see a mass in the fourth portion of duodenum. It's slightly vascular. I could think about lymphoma, though usually they're not vascular. Small bowel adenocarcinoma, mass-like I can think about, but usually it's not vascular. Crohn's, this surely isn't. Then I noticed the left kidney is missing. This was metastatic renal cell carcinoma to the small bowel. Just a beautiful example and something we often don't think about. This patient had shoulder pain, and what do you see? You see abnormalities in the bone, particularly in the humerus, though the scapula is also abnormal. In the humerus, there's this sclerotic type appearance. That's the classic appearance of bone infarcts. It's not prostate, and it's not osteomyelitis, and it's not Paget's. Paget's expands the bone. Prostate, the lesions are very sclerotic. And osteomyelitis, there's more destruction of the surface and soft tissue mass. A beautiful case of sickle cell disease with multiple bone infarctions. This 28-year-old female had pelvic pain. Well, what do you see? Complex cystic masses, which maybe are ovarian. I've seen patients who've had simulation for in vitro with an appearance like this. That wasn't the case here. In theory, despite the age, I couldn't exclude ovarian cancer. This is not a missed appendicitis, and it's not dilated bowel. This was endometriosis. Endometriosis is a difficult diagnosis, many different appearances, and this is one of them. This patient presented with a GI bleed. What's the cause? You see this bulky mass involving the fourth portion of the duodenum to the jejunum. There's actually active extravasation present. Crohn's disease can cause bleeding. It's not a great location. And there you see edematous changes in the wall of the bowel. There's this narrowing. You get the halo effect. This is a malignancy. Now, you can argue what this is. This, in fact, was a GIST tumor, not a great surprise, but it could have been an adenocarcinoma, and based on bulkiness, could have been a lymphoma. The least likely diagnosis is Crohn's disease, and as I mentioned, this was a GIST tumor. 40-year-old female with hepatitis C, what's the diagnosis? You see a 4-centimeter vascular liver lesion that is hypodense on venous phase, and then hepatitis C always makes me think of hepatoma. Hepatic adenoma is a possibility, but usually it becomes closer to isodense, but it's possible. F and H are always isodense, and hemangioma have peripheral puddling. This is not a hemangioma. So really you're stuck between hepatic adenoma and hepatoma. When you're thinking about that, hepatic adenomas can become hepatomas, and also once you have hepatitis C, you better be thinking hepatoma, and this in fact was a hepatoma. Now, I came across this case and I really liked it, so I made it a quiz case. At first, it looked like there's a mass in the pancreatic head pushing on the duodenum, but there's no dilated ducts. So you still would consider pancreatic cancer. Lymphoma, I would consider maybe bulky adenopathy near the pancreas. The one thing, this is not as a cystic lesion like a serous adenoma. Now we know serous adenomas can be solid, they enhance, but this is not enhancing. This is solid, it's pushing on the duodenum. In fact, this was metastatic melanoma to the duodenum, just a terrific case. Remember, melanoma is a great mimicker. Serous adenoma is a great mimicker. Sometimes it's vascular, sometimes it's more cystic or less cystic, but I would not consider it in this case, and so it's the least likely diagnosis. Just a really nice case. The best diagnosis in this case, anterior mediastinal mass, eccentric, calcifications and fat. This is classic for a teratoma. There's nothing else to think about. If it was solid in total, lymphoma would be a consideration. Carcinoid, we're not thinking about that. Thymomas are anterior mediastinal masses, but they don't have fat. They can have calcifications, particularly if they've been treated. So this was a beautiful example of a teratoma. This is a great case. There's a mass, left lobe of liver on MIP with neovascularity. You see it washes out quickly on the venous phase, but it's still there. That's not the vascularity of hemangioma or FNH. At times, hepatic adenomas have a lot of weird shapes, but they do tend to become isodense or nearly isodense. This is a great case of hepatoma, hepatitis C, neovascularity, irregular liver, and a low-density mass on venous phase imaging. So I showed you 10 great cases. I hope you got them right, and I hope you learned something. And with that, I hope to see you next month. Have a great time, and see you later. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the July 2020 CTisus quiz. We hope your summer will be a pleasant one, and we welcome everybody to the new academic year. And we have 10 terrific cases for you, so let's get started. In this first case, I ask you what the most likely diagnosis is. If you look carefully at the images, you can see there's a mass in the pancreas, but the mass is really essentially entirely a fat. It's not a solid mass like an adenocarcinoma or a mass that's solid and maybe cystic like a SPEN tumor or a hypervascular lesion like a neuroendocrine tumor. It's a classic fatty tumor. Lipomas of the pancreas are relatively uncommon. Usually they're small. This is one of the larger ones. It's a benign leave-alone lesion. Obviously, patients with cystic fibrosis have replacement of the pancreas with fat in most cases, but this is a solid lipoma and not a patient with cystic fibrosis. In this next case, I ask, what is the best diagnosis? You can see a filling defect in the region of the left atrial appendage. Now, sometimes you can get fooled. Filling defects can be due to flow related, particularly with poor cardiac output or a large left atrial appendage. Occasionally you get tumors involving the left atrial appendage, but they're irregular, so this is not a sarcoma. And this is circular and round. It's not a fluid level as in a pseudothrombus. That's not the case. And metastatic breast cancer can go to the heart, but usually the pericardium. And this is smooth, and this is a very nice example of a left atrial thrombus. Very nicely shown on both the axial and the coronal imaging. Here's a patient with a left adrenal mass, and I ask you what's the most likely diagnosis. When you look at the lesion, it's about 5 or 6 centimeters, so it's not a small lesion, but it does contain fat, macroscopic fat, as well as punctate calcifications. So what could it be? Well, adenomas rarely contain calcification, and they don't have solid fat. They're low density. Adenomas typically are under 10 Hounsfield units and can be minus 10, but they don't have solid fat. That's what we see with myelolipomas. Yes, I know that occasionally metastasis, pheochromocytoma, or a primary adrenal cortical carcinoma has been reported to contain fat, but the tumors then are large, there's irregular enhancement, and usually the fat is related to invasion of the periadrenal or perirenal fat. This is the classic appearance of a leave-alone myelolipoma. Again, myelolipomas are benign, no malignant potential. Occasionally, they will be removed if they get larger than classically 7 centimeters or if they're causing any symptoms at all to the patient. Now, in this case, I asked for the least likely diagnosis. If you look at the patient's region of the right adrenal gland and right kidney, there's a mass and an infiltrating process. Now, I guess the question is this arising in the adrenal, or maybe nearby in the IVC, or maybe in the retroperitoneum, or maybe in the kidney? Well, if you thought it was from the IVC, it would be an IVC sarcoma. If you thought it was from the adrenal, you could even worry about a malignancy. You could worry about a lesion that bled like a pheo. But what about something like lymphoma involving the peri and pararenal spaces? Well, you could also consider an angiomyolipoma, perhaps, because maybe it was a renal tumor that bled. Well, what are we really dealing with? Well, I remember I said least likely. It could be a lymphoma with perirenal spread. It could be a pheo that bled. It could be an adrenal carcinoma that spread and bled. The one thing is not as an adenoma. Adenomas, occasionally very, very large adenomas, I guess, can theoretically rupture, although I've never seen one. They can bleed, but this is more an infiltrating process, which to me suggests malignancy. And in fact, this was a pheochromocytoma that was malignant, which infiltrated the perirenal space. In this next case, I ask you what's the most likely diagnosis for the left renal mass. You see a mass, non-contrast and contrast, very dense calcifications. You don't see any changes in enhancement. There's no perfusion changes in the remaining kidney. So what can we think about? Well, renal cell carcinomas can contain calcification, but then they would enhance, and the calcifications usually aren't so dense. AMLs occasionally can have calcification, though they're tiny, and AVMs can have like rim calcifications in the vascular component. But at the end of the day, this looks like something that bled. Dense coarse calcifications, be it adrenal, be it renal, be it in the spleen, be it in the liver, you got to think of prior bleeding. And this was due to an old renal hematoma way back when, many years earlier, the patient had renal trauma. So a very nice example. What about this case? Patient with an FUO, what's the best diagnosis for the left kidney? Well, what you see with the left kidney, it's atrophic and it has this unusual pattern of calcifications that seem to match the cortical medullary interface. Remember, that's a non-contrast study, and it looks the same on contrast, and perhaps you're talking about dilated calyces. The contralateral right kidney is fine. There's no perirenal or pararenal space involvement. So what are we dealing with? I guess you could consider chronic pyelo because that gets calcification, but you get small kidneys and you get punctate calcifications. This appearance is strange. It's not a renal cell carcinoma. You can have calcifications in renal cell, but then the lesions are vascular. This is avascular. Obviously, clear cells are markedly hypervascular, but even papillaries are enhancing up to 90 Hounsfield units. It doesn't have the look of a transitional cell carcinoma either. This is a great example of tuberculosis. Very nice atrophic kidney, linear calcifications. Sometimes with TB, you could see strictures in the ureter, strictures in the renal pelvis, calyceal strictures, papillary necrosis, and even a small non-functioning atrophic calcified kidney. TB is rare, but it does occur, and this was one very nice example. In this patient, I asked you what's the most likely diagnosis. If you look at the images, you have a process that involves the lower lungs greater than the upper lungs. You see bronchiectasis, you see interstitial changes. It's not the appearance of lung cancer. It's not an appearance of lymphangitic spread. It's not a PE. I didn't even show you any soft tissue windows. And it's not going to be lymphoma, as we can consider those as possibilities. We could also consider COVID-19, but this is not the pattern of COVID-19 pneumonia. We could also consider sarcoid, but that typically involves the upper rather than the lower lungs. And IPF is a consideration, but the bronchiectatic changes, as well as the fact The patient has a dilated esophagus, pushes us to scleroderma, and this was scleroderma. Just a very, very nice example. Central versus peripheral, bronchiectasis, interstitial changes, lower lungs greater than upper lungs. In this patient with shortness of breath, what's the best diagnosis? When you look at the imaging, the first thing you see is what looks like a big mass by the left hilum. Maybe it's simply just a lung cancer, but then you look and it's invading the pulmonary artery. And you say, well, maybe it's a lung cancer invading the pulmonary artery. Now, truthfully, with lung cancer, particularly non-small cell, pulmonary involvement is common, but it's usually encasement and narrowing of the pulmonary artery. Here it's growing into, but maybe think of it differently. What if this was growing out of the pulmonary artery? And so you look and you say, it could be a small cell. It's not a P, it's too big. Lymphoma is a possibility, but lymphoma, again, is typically compression or displacement of the vessels, not invasion. This was the unusual diagnosis of pulmonary artery sarcoma. Remember, they're often diagnosed when they're smaller as large PEs, sometimes the equivalent of saddle emboli, but it persists, and they go in to do a thrombectomy, and it's a solid tumor. So it's rare, it's aggressive, and something you want to consider. Here's an interesting case. There's a cystic lesion in the patient's upper pole right kidney. There is some rim enhancement. There is some nodularity, maybe at about 7 o'clock, and there is a septation. And you can see the findings both on the arterial and on the late phase imaging. So you ask the question, what could this be? Bosniak 1 cyst is a simple cyst. Bosniak 2 cyst is a simple cyst with a thin septation. But once you have nodularity, you got a tumor. It's not an abscess. The patient wasn't febrile, and this is not an abscess. Abscesses walls are more irregular. The center is not so cystic. This was an unusual case. I would be highly suspicious this is malignancy. I would have picked maybe there's a papillary renal cell within a cystic wall. This was a transitional cell carcinoma arising in the wall of a cyst. That's a bit atypical, but you have to remember this is a malignancy. Do not just simply follow this case like you are following a Bosniak 2 or Bosniak 2F cyst. So just a very nice example. In this case, I'm asking you for the least likely diagnosis in this patient with fever. What are you seeing in this case? You're seeing infiltration, lack of cortical medullary differentiation early and late in the patient's left kidney, and it looks like it encases the left renal artery, and encases maybe the right renal artery, encases the patient's renal vein. This could be lymphoma. Lymphoma infiltrates the kidney and perirenal involvement. It could be TCC, a transitional cell. Again, we don't have the entire kidney, but transitional cell can be diffusely infiltrating. And it can be a papillary renal cell. That's probably the least favorite of the malignancies, but again, we only have a couple sections, and papillaries can be infiltrative. They're usually the more well-defined masses. The one thing that I don't like for this case is pyelonephritis. Yes, pyelo can give perfusion changes and decreased enhancement, but not early and late, and not the entire kidney as we see it. And you cannot explain the perirenal involvement and the involvement around the vessels. So the least likely diagnosis is acute pyelonephritis. Well, that's 10 terrific cases. Hopefully you got all the answers correctly, but as with all of our quizzes, the purpose is not to get the answers correctly this time, it's to get them correct the next time when you see it in practice. So hopefully we've taught you something, and with that, have a great day.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctassist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the August 2020 CTSS quiz. We've collected 10 terrific cases for you. We hope you enjoy them, and let's get started. In this first case, I ask, what is the most likely diagnosis? If you look at the images, you see what looks like at first a cystic lesion, but then you realize that's the entire pancreas, and you look at it on the axials and then coronal views, you realize what you're dealing with is a long tubular cystic lesion, which, again, you might be thinking about different cystic tumors. Then you recognize you're really looking at the patient's main pancreatic duct. The whole duct is markedly dilated. So when you think about it that way and you look at the answers, it's not a pancreatic adenocarcinoma, but it could become one. I don't see a solid mass at this point. It's not a serous adenoma or a pseudocyst. Those could be cystic lesions, but this is a main duct IPMN. It's a little bit unusual in terms of appearance. Usually we see more pancreatic tissue around the duct. Often the ducts will be large throughout the gland, but not necessarily. And this is just a really good representation of a bit of an atypical case. If you look a little bit closer at the area of the pancreatic duct here near the head of the pancreas, there was actually an early foci, and this patient had a high-grade dysplasia in a main duct IPMN. Remember, everyone considers main duct IPMNs to be pre-malignant or malignant etiologies, and those patients will get either a Whipple's procedure or a total pancreatectomy, depending on the scenario. In this case, I asked, what's the most likely diagnosis? And there are 4 really good choices. If you look at the case, now what you see is a dilated pancreatic duct and a transition in the junction of body and neck of pancreas. If you look very carefully at these 2 coronal views, you see there's a soft tissue density which abruptly cuts off the patient's pancreatic duct. Remember what we say is if you see a dilated pancreatic duct, it's pancreatic cancer till proven otherwise when there's an abrupt cutoff of that duct. Yes, we could see an enhancing lesion like a neuroendocrine tumor, which causes a desmoplastic reaction obstructing the duct, but then you would see an enhancing lesion. So when I think about what this could be, it's not a main duct IPMN, it's not a serous adenoma, and it's not a pseudocyst. It's a classic pancreatic adenocarcinoma with a main duct cutoff. Just a very nice example of that etiology. The most likely diagnosis in this case is, and I've given you 4 choices. When you look at the images, you see what it looks like an enhancing lesion in part with some draping of vessels in the head of the pancreas. There's no dilated pancreatic duct, though I admit it's hard to see the pancreas in detail. There's no intrahepatic ducts. The lesion is enhancing, and it pushes on the duodenum. So when you think about it, the first thing to ask yourself is, where is the lesion starting? So I'm saying it's pancreas, and it's not duodenum, and it's not in the pancreaticoduodenal groove. And then you say, what are the possibilities? Well, one possibility, of course, is that this could be a neuroendocrine tumor. Spen tumor, not so vascular. Serous adenoma. Well, remember we've said that serous adenomas can look like neuroendocrine tumors, but the vessels are stretched and the enhancement is not as great. And if you look really hard and often on the venous phase imaging, the cystic paces are better seen. So this was not a neuroendocrine tumor, and this was not an adenocarcinoma. This was a serous adenoma. Again, serous adenomas, Linda Chu wrote a paper a couple of years ago, can be very vascular. They splay the vessels. It can be somewhat tricky separating from a neuroendocrine, but the most likely diagnosis is B, a serous adenoma. The best diagnosis in this case is, well, you see a liver mass. It's vascular in the 6 or 7 centimeter range. The liver is not cirrhotic. And when you look and you go from arterial to venous, the lesion is barely visible. When you look at the arterial phase, in addition to the homogeneous enhancement, it enhances like the IVC in terms of brightness, not the aorta. There's also a central scar. And yes, I know central scars can be seen with hemangiomas or even hepatomas, but the classic lesion, vascular as bright as the IVC, central scar, quickly becomes isodense, is very classic for focal nodular hyperplasia. Hepatomas, hepatic adenomas, and hemangiomas, all in their own right, can become isodense, but hemangiomas have peripheral puddling. Hepatic adenomas don't have that central scar, nor do they have that homogeneous enhancement. And hepatomas tend to be more irregular in terms of enhancement and in terms of shape. The best diagnosis in this case is focal nodular hyperplasia. What's the most likely diagnosis in this case? Well, I see a mass, and the first thing is trying to figure out, is this mass coming from the stomach or from the spleen? On the axials, I would be hard-pressed to be certain. On the coronal views, I think there's calcification in the lesion, and I think it's simply probably going to be pushing on the patient's spleen. So then you think about, what could it be? Well, if it was splenic and primary, you could think of splenic lymphoma. But really, when you look at it, it really is gastric. Now, the thing about it, it's exophytic, and lymphomas can be at times exophytic, but they're more bulky. Adenocarcinoma is typically more infiltrative and not exophytic. This is a classic appearance of a GIST tumor. Now, it's not the most classic GIST tumor I've seen, and it is somewhat difficult, and at times when GIST tumors push against the spleen or go toward the adrenal bed or pancreas, it can be somewhat confusing, but the homogeneous enhancement, the calcification, all push me to the right answer, which is a GIST tumor. Now, in this case, what's the best diagnosis in this 50-ish-year-old female? Well, what do you see? You see a cystic lesion in the body tail of pancreas, but the lesion has septations within it and almost a soft tissue component. Yes, you could think about a Serocystenomas, and at times SPEN tumors can be cystic, though the age is bad. IPMNs can have septations, but then you would have to worry this is an IPMN with malignancy. Also, it's large for an IPMN. The hint that the patient's in their 50s pushed me to the lesion of an MCN, mucinous cystic neoplasm. These lesions can have septations, they have ovarian stroma within them, and you can see the soft tissue densities within the mass, and this was an MCN. MCNs are at a minimum pre-malignant, so they will be resected. So just a very, very nice example. In this case, the patient's 20-ish, and we see a pancreatic mass. What pancreatic masses occur in 20-year-olds? It's not going to be the typical adenocarcinoma or even IPMNs unless the patient has maybe von Hippel-Lindau. Mucinous cystic neoplasms of patients in their 40s and 50s and more commonly in the body. Serocystenomas is something we always consider. I've showed you some examples recently of very atypical serocystenomas, though this is not as cystic as a typical serous or even an atypical serocystennoma. So that brings me back to the 20-year-old, and the best diagnosis is a SPEN tumor, solid papillary epithelial neoplasm. Usually in the teens, can be cystic or solid or a combination of both. Very sharply marginated here, which is a very classic finding with SPEN tumors. Now, what's the most likely diagnosis in this case? What I'm showing you are bilateral adrenals that are calcified. Okay, very straightforward. The adrenals are calcified and they're small. What can cause this? Well, prior hemorrhage can cause that, but bilateral prior hemorrhage, the patient would be Addisonian. Okay, this patient wasn't. Neuroblastoma, you would see masses. Neuroblastomas commonly have calcifications, but not the small. They're large masses with calcification. And myelolipoma, you'll see the fat and punctate calcifications, and they're not bilateral. This is good for TB or histoplasmosis, so histo is the best diagnosis. Small atrophic adrenal glands. Patients with histo and or TB can become Addisonian, so that's an important diagnosis to make. What's the most likely diagnosis in this case? It's interesting, you see a mass in the pelvis on the left side that seems to be enhancing, and indeed it was. I guess in theory, without delayed images or pre-images, you could say maybe this calcification, but I'll tell you, this was all enhancement. And then you say, where is it? Is it in the pelvis? Is it a pelvic mass? Well, you notice it's coming from the small bowel, or it's at least adjacent to the small bowel. One of the things about small bowel tumors, particularly GIST tumors, they grow exophytically, and sometimes you really don't recognize where they come from. Lymphomas are solid masses, can be multiple various appearances in the small bowel, but they do not enhance. Adenocarcinoma, infiltrative, can be bulky, but again does not enhance. And this is not unopacified small bowel. So this was the best diagnosis is a GIST tumor. If I would have said carcinoid in the possibilities, that wouldn't be bad as well. Though I think when I see something coming off the bowel and being exophytic, I think GIST, intraluminal, then I'm more compulsive for saying carcinoid tumor. Now this is an interesting case. This patient had a history of GI bleed. And when you look at it, particularly well seen on the MIP, is those prominent vessels in the patient's cecum. Really prominent vessels. There's also some prominent vessels, though less well visualized in the patient's descending colon at the level of the crest. And you can see the prominent vessels as you look at the patient's MIP imaging. So the best diagnosis, this is not a Sickle cancer, though cancers can have increased vascularity. It's not lymphoma, and it's not the appearance of Crohn's. Crohn's, you get a comb sign, and you see thickened bowel. This is angiodysplasia. Very nice example, angiodysplasia with AVMs in the patient's cecum. This is not an uncommon cause of bleeding, can be seen in large bowel or small bowel. So with that, I've shown you 10 terrific cases. I hope you enjoyed the cases. I hope you got them right. But more importantly, I hope you learned something from the cases. So with that, I thank you for your attention, and I'll see you next time. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to September 2020 CT is Us quiz. Hopefully this will be a wonderful fall season for all of us. Hopefully you've enjoyed the summer, but the summer leads to the fall, and the fall leads to the September CT is Us quiz. In this case, I asked the most likely diagnosis in this patient with a palpable abdominal mass is, and if you look at the two images, you see a large mass, which kind of looks solid but somewhat cystic. It has some enhancement. There's vessels particularly around the lesion, but also vessels through the lesion. It's pushing on the stomach, and if you look at it, you can say to yourself, where's this beginning? Could it be stomach, like a GIST tumor? Though funny enhancement. Could be something from the pancreas. Could be something from the duodenum. And then you look at the choices. Lymphoma. Lymphomas are typically hypovascular and solid masses. Similarly, GIST tumors can be somewhat vascular, but this is too much vascularity, and particularly the stranding and the periphery of the lesion, that stretching of vessels. Neuroendocrine tumors are vascular, but not with this appearance. They're usually hypervascular centrally, and this would be a large neuroendocrine tumor, which are typically very vascular. This was a serous cystadenoma. Serous cystadenomas have sometimes unusual appearances. When you look hard, you appreciate the cysts and you appreciate the stretching of the vessels around the lesion. This patient will have the lesion removed. It was palpable. Patients with serous cystadenomas will have them resected when they're large. Not because of fear of malignancy. These lesions never become malignant, but they can cause symptoms because they can continue to grow and compress the stomach, as in this case, create symptoms or create symptoms related to compression of vessels. So just a very nice example. In this 40-ish-year-old female, what's the best diagnosis? Well, you see a cystic lesion really near the tail of the pancreas, and it's hanging down just a little bit. Well, what could this be? Well, I gave you 40-ish, and 40-ish I'm always thinking MCN. IPMNs are also common in that age group. Truthfully, serous cystadenomas and pseudocysts can be as well. There's no evidence of any inflammatory changes, so pseudocysts a bit less likely. This could be a serous cystadenoma, but there are no septations. You can get an oleocystic type of serous cystadenoma, but that's a thought. IPMN, kind of hanging off like that, no dilated pancreatic duct. That's a bit atypical. The best diagnosis is really going to be between a mucinous cystic neoplasm and a serous neoplasm. And I think because of the way the lesion is sitting, because of the patient's age, I would go with a mucinous cystic neoplasm, which indeed this was. The best diagnosis in this case, what's interesting is you see fatty infiltration of the liver, and at first glance you say, well, maybe that area in the right lobe is simply normal tissue, maybe it's perfusion changes, but especially on the venous images, you recognize that there's a mass present in the 4-centimeter range. So this patient, in fact, did have NASH. This was not focal normal liver sparing, and this was not cirrhosis. This was a hepatoma. Increasing incidence of NASH will lead to increased incidence of hepatoma. Sometimes within fatty liver, it can be confusing. You can miss liver mets. You can miss primary tumors. This was a hepatoma. The most likely diagnosis in this 25-year-old female, it's interesting. You have a cystic lesion coming off the tail of the pancreas. Well-defined, sharply marginated. You can see the stomach out in front. Well, what could this be? Now, again, when I give you a 25-year-old female, whenever I give you an age young, you have to really think about a SPEN tumor. Again, Serocystenomas possible. Pancreatic pseudocyst, no other changes, unlikely. And it could be a Serocystenomas without septations. They're rare, the oligocystic type. But the best diagnosis, I think, in this case, again, I also considered a cystic neuroendocrine tumor. But there, of course, you're going to see solid components, at least in the wall and enhancement. So the best diagnosis in this case is a SPEN tumor. SPEN tumors have a variable appearance, mixing solid and cystic at times, but they can be perfectly cystic, as in this case. Just a really nice example. Now, this 30-ish-year-old had HIV, and I asked, what's the most likely diagnosis? Well, when you look at these images carefully, you see that the patient has an inflammatory process with some consolidation. There's airspace filling. This really looks like pneumonia. Lymphangitic spread, not really. Pulmonary hemorrhage is more central. COVID pneumonia tends to be dominant toward the lower lung fields, and they can get GGOs, you can get crazy paving, all sorts of appearances. But this is more likely, particularly with HIV, going to be PCP pneumonia, which in fact this was. In this 40-ish-year-old male, what's the best diagnosis? And you look at it and you say it's a cystic lesion of the pancreas. What could this be? If you look at the coronals, it's kind of coming off the gland. Now, I will admit in this case, if you said an IPMN, it's kind of large. If you said an MCN, again, more common in females, but I guess it could be. If you said a Serocystenomas, it theoretically could be. But I was trying to get you to say in this case, by the images I gave you, whether the lesion is cystic, well-defined, no septations, no enhancement, and it seems to be almost peripancreatic rather than coming from the pancreas, and that's the classic appearance of a lymphoepithelial cyst. Lymphoepithelial cysts are benign, they can potentially grow. We tend not to biopsy them or remove them if possible if we're certain of the diagnosis, because they get terrible pancreatitis post-op. So if you know it's lymphoepithelial cyst and you need to document it with the US, fine, but you prefer not to do surgery. And this patient was simply followed. The CT findings in this case, what's the best finding? Well, the first thing you notice when you look at the images, look on the outside. Patient has multiple soft tissue masses. This is neurofibromatosis, not much else. Then you look at the bowel, and there are multiple enhancing lesions in the small bowel. Enhancing lesion, small bowel, could be a carcinoid, could be a GIST tumor. Unlikely to be lymphoma, they're hypovascular, and unlikely to be adenocarcinoma. Then you say, what lesions are more common? Multiple, but I guess typically carcinoids and GIST are solitary, but they can be multiple in select instances. But this patient had neurofibromatosis. Vascular lesions, small bowel, and neurofibromatosis are classic for GIST tumors. And this was multiple GIST tumors, a very, very nice example. This patient was several days post C-section, had fever. What's the best diagnosis? Now, we often will do scans when we're looking for a post-op process like a bleed, an abscess, pulmonary emboli, gonadal vein thrombosis, pyelonephritis, obstructing stone, you name it. You look carefully here, there's a mottled density in the central portion of the abdomen on the axial views, and you see it on the coronal view. And you say, what, am I dealing with an abscess? Possibly. It doesn't look like a bleed post-op. The uterus looks pretty good post-op. But really, when you think about it, the word is post-op. And there's some mottled density and mass. And that's the appearance of a glossy phiboma, which is a fancy word for saying something left behind. This was a surgical towel. Now you could always say, how did you leave it? The count was correct after, but this was a blue towel left behind. The patient had to have surgery for it to be removed. Again, foreign bodies are not uncommon. They present with FUOs commonly. They can be confused with tumor recurrence, unopacified bowel, or an abscess. Remember now, we like to have rings on towels, and this was not a ring, so many things wrong. But again, it's something you need to be very careful about, and you want to make the diagnosis, and this will need to be removed, but you don't want to miss the diagnosis. This patient had mediastinal whining. What's the best diagnosis? And I gave you 4 choices, but when you look at the images, either you recognize it or you don't. The main pulmonary artery and right pulmonary artery look good, but where's the left pulmonary artery? It's going behind the trachea and then coming across right to left. That's the classic appearance of anomalous course of the left pulmonary artery or a pulmonary sling. The key thing is to recognize it and not confuse it with something else. No further workup is necessary. This is not a PE, and it's not a dissection, and it's not a normal study. So pulmonary artery sling, great example. Now, this patient had abdominal distension, and I'm asking what's the best diagnosis. When you look, the bowel is displaced, the kidneys are displaced, and there's some soft tissue infiltration of the entire abdomen. When you look, it's not fluid, and when you look at it and measure it, you recognize it's fat. There's fat infiltrating the abdomen, septation, soft tissue density, displacement of bowel, displacement of kidney. Lipomatosis is something we could say patients on steroids, but they don't have this mass effect and it's not as extensive. This is not blood and it's not paniculitis. This is a classic example of a liposarcoma. Liposarcomas are the most common retroperitoneal malignancy. This is a little bit unusual in that it infiltrates the entire abdomen, but that was the diagnosis, liposarcoma. So those are 10 really good cases. I focused a bit on the pancreas. I hope you liked the cases. I hope you understood the cases, and I hope you learned something from the cases. And with that, see you next month.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to our latest quiz. This is the October 2020 quiz. We're moving into the fall, so let's see what we can do. I have 10 terrific cases for you, and without further ado, let's get started. In this patient with abdominal pain and weight loss, I ask you what's the best diagnosis. When you look at the images, what you see is that the body and tail of the pancreas have a different attenuation than the head of the pancreas, but also it's edematous, and what you see is a low-density halo around the pancreas. Now, when you look at the choices, you say, could this be carcinoma? I guess you would have to say there's a proximal lesion, and that's why the pancreas looks different, but then you would see a dilated duct. Lymphoma can be diffusely infiltrating, but that halo I'm describing is not something you would see, and isolated pancreatic lymphoma obviously is exceedingly rare. So now we're dealing with 2 choices, B or D, or acute pancreatitis or autoimmune pancreatitis. Well, the answer surely is pancreatitis. They each have that word. But to be more precise, the halo around the lesion, the diffuse edema, is classic for acute pancreatitis, but it's really classic for autoimmune pancreatitis. And so with autoimmune pancreatitis, you have a halo, you have diffuse enlargement of the gland. Remember, treatment with autoimmune pancreatitis is simply steroids for 2 weeks, and then the pancreas will decrease in size. This case, I don't think I would confuse with a cancer, but remember at times, autoimmune pancreatitis can be confusing with a mass, as it can present as a pancreatic head mass, for example, with dilated pancreatic duct and dilated common duct. In this case, I ask you what's the least likely diagnosis, and there's 4 choices. Well, let's look at the images. What you can see on the axial images, there's a large infiltrating tumor in the hilum of the liver that's obstructing the intrahepatic ductal system. When you think about that image alone, you're saying to yourself there's a tumor. Could it be hepatoma? Well, hepatoma usually doesn't give dilated ducts. Could it be a cholangiocarcinoma? It's possible. Could it be what else? Well, tumors that infiltrate into the hilum can also be lymphoma. When you look at the image on the right, the MIP image, you can see the encasement of the portal vein. It's patent, but it's narrowed. And truthfully, cholangios or lymphoma, or in fact hepatoma, can do this. So when you look at the choices, those are 3 good choices. The one thing, this is not is simply hepatitis. Hepatitis can cause textural change, but it doesn't cause the mass effect like this. You can see acute hepatitis compressing and stretching arterial structures and even at times venous structures, but not this encasement. This, in fact, was lymphoma. My second choice would have been cholangio. Third and distant choice would have been hepatoma. But the least likely diagnosis would have been acute hepatitis. This patient developed a fever 2 weeks post-colon surgery, and a CT was done to look for the cause. When you look, you see a mass in the left side of the abdomen, and in the images with the positive contrast, the contrast is around the mass. And at first glance, you say, well, this must be an interloop abscess. There's air, there's some mottled density. That's a good possibility. But I think once you've seen this before, you recognize what you're dealing with is a surgical towel that's left behind. There are no markers on this towel, but you can see the ridges of the towel, and once you've seen that appearance, you recognize it. Obviously, you could have said, well, how do I know this is not recurrent tumor? How do I know it's not an abscess or a pseudotumor? That appearance is almost like an Ann Mini. It's very classic, and it's a retained surgical towel. Look carefully at this case and remember it. We've seen a number of cases like that. The most likely diagnosis in this case is, if you look at the lesion, we have a complex cystic lesion in the liver. There are no dilated ducts. The lesions have septations but no calcifications. I would admit I could consider hydatid disease based on septations, but typically, well, that's rare and usually endemic to certain parts of the world. But also with hydatid disease, you would see calcifications in 70% of the time. You can have cystic hepatoma, but this is just too cystic. You can have a GIST tumor metastasizing to the liver. It's one of the causes, as is ovarian cancer, of cystic liver mets, but the septations are truthfully too much. This was an excellent example of a biliary cystadenoma, and that's the correct answer. This patient has shortness of breath, and the question is, what's the best diagnosis? This is a tricky case. What you first notice on these images is there's adenopathy present, and it looks like infiltration going from the hilum into the lung. There are patchy infiltrates and ground glass infiltrates bilaterally, and perhaps you do entertain, could this be simply pneumonia? But with the infiltration, the solid components, you got to think about malignancy. Now, there could be some pulmonary edema component, but there is mass effect here. It's not simply a pneumonia. Sarcoid would be a good thought, though often the nodes are going to be in part calcified, and sarcoid usually is patchy and not so perihilar. When you see a perihilar process, you're really thinking of something that's infiltrating, and you got to think of malignancy. At times, tumor, lung cancer itself, can infiltrate with spread along the arcade of the lung parenchyma, but this is just a very nice example, and the best answer here was lymphoma. A very unusual appearance for lymphoma, but one that does occur. This patient had symptoms of flushing, and the best diagnosis is, well, the truth is, if you say flushing, I would say carcinoid tumor without looking at the patient's images, but let's look at the images. What you see particularly well shown on the 3D volume rendered image is a 1 centimeter or so enhancing lesion in the patient's ileum. The bowel is dilated. There's also some prominent vessels feeding it. When I see a vascular lesion in the small bowel, if I only looked at the vascular lesion, I would say carcinoid or GIST or even theoretically metastasis like from renal cell carcinoma. When I start seeing the desmoplastic reaction, that pushes me to carcinoid. Lymphoma is unlikely. That's typically not vascular. This is not retained foreign matter. So if I have to pick a choice, I'm going with carcinoid, and that's the correct answer because of the desmoplastic reaction as well as the location in the distal small bowel. GIST tumors are more common in the duodenum, but we see them anywhere. In this middle-aged female, the best diagnosis is we're looking at a mass in the patient's liver. The mass has a pseudocapsule. It's low density. The liver is not cirrhotic. This looks like an aggressive tumor. It also has calcifications. So what could you think about? Cholangiocarcinoma is definitely a possibility. Can be mass-like. Sometimes it dilates the ducts. Hepatoma is possible, usually more common in a cirrhotic liver, but I couldn't exclude it. FNH, this is not the appearance of FNH. Focal nodular hyperplasia enhances homogeneously, looks like the IVC, does not have a pseudocapsule and becomes isodense over time. This calcification in the lesion makes me think of what tumors have calcifications in the liver, occasionally metastasis from mucinous tumors like adenocarcinoma, but typically when it's a mass like this and you're thinking about a hepatoma, but it's not a cirrhotic liver, and you see calcification, that's a fibrolamellar hepatoma. Also, fibrolamellar hepatomas are more common in patients in their 40s and 50s. So just a very nice diagnosis. This patient had left lower quadrant pain, and I asked you what the best diagnosis is. When you look at the images, you see an inflammatory process with looks like multiple air bubbles. Perhaps it's a perforation. You could see his epicenter is not the colon, but it's the small bowel. And when you look carefully at this small bowel, there are multiple little outpouchings or diverticuli. This is a classic appearance for jejunal diverticulitis. We think about colon diverticular disease and diverticulitis commonly. We think about duodenal diverticuli, but it's rarely thinking about jejunal or ileal diverticulitis. It's an uncommon process, but presents as acute inflammatory process, can be managed conservatively if you make the diagnosis. Obviously, it can be confused with a perforation of the colon. You could think about Crohn's disease or other inflammatory etiologies. Again, the mesenteric component is critical, but also the outpouchings of air, which at first you say maybe it's just free air. Then you realize you're dealing with diverticuli, and this was jejunal diverticulitis, a wonderful case. In this patient with abdominal pain, I asked for the best diagnosis, and the finding on the axial and the coronal is about a 3 centimeter enhancing mass in the antrum of the stomach. You then say to yourself, what lesions in the stomach can enhance? Well, you could have ectopic pancreas, usually it's smaller. You can have metastasis from, say, renal cell carcinoma, but that's not the case here. You can have GIST tumors, which can enhance. That's a possibility. But you also can have carcinoid tumors. Carcinoid tumors do occur in the stomach, and they're typically vascular. Gastric adenocarcinoma is usually not so round, but doesn't enhance. Lymphoma is infiltrating and doesn't enhance. Occasionally, gastric polyps can be vascular and simulate other malignancies. But in this case, the best answer, a mass in the antrum enhancing carcinoid tumor of the antrum. An unusual gastric tumor, but one you need to think about when you see a vascular gastric lesion. In this teenager, the best diagnosis is which of the following masses. So the first thing, of course, you have to think is what's common in teenagers. So if I don't look at the images, FNH is usually in the 20s and 30s. There's a chance. Hepatic adenoma is similar. Angiosarcoma is very rare. Can be due to radiation. Can be due to vinyl chloride. And then you say hepatoblastoma. That's kids, single digits or in their teens. So already without looking at this, I'm thinking about hepatoblastoma, though of course I need to look at the images because maybe I'm just throwing you a curve. When you look at the images, you see a large mass arising from the liver. There's central septations. It's pretty well encapsulated. And when you think about it, so now we're dealing with a hepatic mass. This is not the appearance of FNH or hepatic adenoma. Angiosarcomas are very vascular. This is a great appearance for hepatoblastoma. Large masses, often with calcification, usually vascular. Central scar is common, and the central scar here is very dominant. This was hepatoblastoma. So with that, I've given you 10 terrific cases. Hopefully you got them all right. If you didn't get them all right, hopefully you learned something. And hopefully you're looking at our app on the Apple Store, which is the CTisus quiz, which has over 1,000 cases from all our monthly studies for more than the past decade. And with that, have a great day.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the November 2020 CTisus quiz. This is a November to remember because we will remember the year we did not have an RSNA. I know it's going to be virtual, but that's not RSNA. Anyway, we got 10 great cases, and let's take a look. This patient has cough and fever and hematuria, and what's the best diagnosis? You can tell I'm trying to tell you something. The patient has chest symptoms and kidney symptoms. You look at the images, there's collapse of the left upper lobe, and there's thickening of the left mainstem bronchus. Now you could think about a lung cancer perhaps with infiltration or some other malignancy. You also need to think about some of the vasculitis. So when you look at the choices, this is not pneumonia and it's not COVID pneumonia. This is not a foreign body. This was Wegener's granulomatosis. So I made it very easy for you. Wegener's, there's a range of appearances in the lung. Patients often can have multi-system involvement, including hematuria. So just a very nice example of narrowing of the left upper lung bronchus, narrowing of the left mainstem bronchus due to Wegener's granulomatosis. This patient had high calcium, fatigue, and memory loss, and I asked for the best diagnosis. When you look at the images, you see a 1 centimeter nodule anterior mediastinum, which on the cinematic rendering beautifully sits near the innominate vein and near the ascending aorta. When you think about this, you got to think about what goes in that area. Well, it could be a thymoma, could be a small lymph node. Those are the two things that I think about the most. And when you look at my choices, lung cancer, I don't see a cancer, but it could be a node for that, I guess, in theory. I mentioned thymoma, anterior mediastinum is the location of choice. And lymphoma, though, in a 1 centimeter node is going to be unlikely. But this is enhancing as well, and the patient had a high calcium and fatigue and memory loss. That's a very good history for a patient with a parathyroid adenoma. Now, most parathyroid adenomas occur in the neck, but if you don't find it in the neck, you got to look in the mediastinum because they can occur from the hilum on up. And this was a beautiful example of an ectopic parathyroid adenoma that was resected. The most likely diagnosis in this case is, when you look at the image, you first look at the image on your left and you see decreased enhancement of a portion of the kidney. So you're thinking about infarct versus infection. But when you look at the CT angio, you see that the renal artery is pruned and the branch vessels are cut off. That's a classic example of vessel occlusion and renal infarction. Pyelonephritis can give you decreased enhancement, but not the vascular component. This is not transitional cell carcinoma, and this is not renal cell carcinoma. A beautiful example of a renal infarct. The most likely diagnosis for the mass near the hilum of the spleen is, well, let's look at the mass. It's vascular, but most importantly, its enhancement looks identical to the spleen on arterial phase imaging with a moire pattern. On venous phase imaging, it washes out and is hypodense, looking identical to the spleen. Well, we always make the point that if something looks like the spleen early and late, that it's probably the spleen. And so the answer here is an accessory spleen. Lymphoma can occur in that region, but it's not going to be vascular. Pancreatic adenocarcinoma is hypovascular as well. So what about a neuroendocrine tumor? The differential is often neuroendocrine tumor versus accessory spleen. And the way you can tell things apart is that neuroendocrine tumors are usually more vascular, but also the moire pattern and the matching of the splenic enhancement with the accessory spleen. That makes life very easy. The most likely diagnosis in this case, you see a lesion within the antrum of the stomach that's vascular. There's no doubt about it. I see no adenopathy. I see nothing else. So what could this be? I've seen polyps on a stalk that are vascular. I guess it could be a polyp. Gist tumors usually aren't that vascular, but they can be vascular, particularly in small bowel, but occasionally stomach. And pancreatic arrests, which are vascular, can occur in the antrum, though most commonly they're in the duodenum. This, in fact, however, was a gastric carcinoid tumor. Those occur in the stomach. They're often small and vascular. They'll be resected. The patient will do fine. Carcinoid tumors in small bowel, large bowel, colon, and esophagus are all often hypervascular. So in this case, there really is no wrong answer, but the answer I liked best was the gastric carcinoid tumor. The least likely diagnosis in this case is you see a over 10 centimeter cystic lesion by the tail of the pancreas. Now, one can argue and say, am I sure it's pancreas? Maybe it's spleen, maybe it's adrenal. The truth is, you could argue for that, but I didn't give you any choices but pancreatic lesions. Cystic lesion and rim enhancement, what could it be? Could be a neuroendocrine tumor. That's a good possibility, very vascular. Serocystenomas can be vascular, compressed vessels, and be cystic, obviously they are. And mucinocystic neoplasms or cystic can be large, great location, but a little bit too much enhancement. The one thing this is not going to be is adenocarcinoma. Those lesions are hypovascular, minimal vascularity, solid. So that's the answer, the least likely diagnosis. And yes, by the way, this was a neuroendocrine tumor. The least likely diagnosis in this case, well, I see two very large kidneys with lack of cortical medullary differentiation. The kidneys both function, but I think when I look at them and describe them, they're infiltrated. So a lymphoma is a great choice, and this was actually lymphoma, by the way. But acute renal injury from dehydration or even some chemotherapies are possibilities. Drug reaction with some degree of renal shutdown is indeed a possibility. The one thing this is not is a normal kidney. Normal kidneys have cortical medullary differentiation that is not as large, they're not diffusely infiltrated. This is a wonderful example of lymphoma. The most likely diagnosis in this case is you look and you see a soft tissue mass infiltrating into the root of the mesentery. It's low density. Well, could it be a lymphangioma? The answer is yes, and in fact this is a lymphangioma. Lymphangiomas can be cystic, they can be low density, they can be infiltrating. Mesenteritis gives you a hazy mesentery. It's not this appearance. Lymphoma is solid. This is not solid. And liposarcomas are fat density, and they can go into the retroperitoneum. So I guess theoretically 100% I couldn't exclude liposarcoma, but the appearance, the model density, the low density, all favors a lymphangioma, which this indeed was. Just a wonderful example of that. The least likely diagnosis in this case is, well, there's a large cystic lesion. Now, I have to scratch my head a bit and say, well, is this pancreatic? If it's pancreatic, then I'm thinking of a serocystic adenoma. I'm thinking of a lymphoepithelial cyst, maybe an unusual MCN. Could this be duodenum? Maybe it's a duplication cyst. Could this be off the adrenal like a big cyst? Could this be coming off the stomach like a duplication, or if the duodenum being a duplication cyst? There are a number of possibilities. When you look at this, I'm asking for the least likely diagnosis. Big cystic mass, lymphangioma, you saw a case previously, I showed you it's low density, but lymphangiomas can be cystic, and in fact, this was a very unusual lympangioma. Serocystic adenoma, great possibility, as is a duplication cyst, likely duodenum. So all those are possibilities, and as I mentioned, this was a lymphangioma, but lymphoma is not going to be the diagnosis. Because lymphoma is solid, lymphoma can be somewhat cystic or low density post-therapy, not this large. So great case. This case, patients post-op with fever, what's the best diagnosis? You see a large mass and bowel is draped around it. First thought you have always is an interloop abscess, but then you look more carefully at the image on your left and you swear I've seen this before. Well, you look, there's a lot of swirls there. I guess you could think about an abscess, but it's very well defined, but sometimes abscesses are, particularly interloop abscesses. Recurrent tumor, I guess you need to think about it, but it was soon post-op. It's surely not an intussusception. What this is the CT appearance of a retained foreign body, and this was a sponge. Yes, the count of sponges was normal. We always see normal counts when a needle or a sponge is left behind, but just a beautiful example of a retained foreign body, which was a towel. So, with that, I've given you 10 absolutely terrific cases, 10 cases that will help you forget all about the RSNA till hopefully November 2021. And with that, have a great day.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman. Welcome to our December 2020 CTSS quiz. It seems like only yesterday we were doing the January 2020 CTSS quiz. So this is the last quiz for the year. We have 10 terrific cases, and let's see how good you are and how much you've learned this past year. In this case, what's the most likely diagnosis in a 30-ish-year-old female? You have to like the answers I gave. They're all kind of eponyms. Peanut, MCN, SPEN, and PADC. Oh yes, PADC is Pancreatic Adenocarcinoma, just in case you didn't know what a PADC was. Well, what we see here is a mass in the tail of the pancreas. It's cystic and it's solid and has coarse calcifications. The fact is it's not very vascular and it could be a neuroendocrine tumor. But a 30-ish-year-old female, I'm going with a SPEN tumor, solid and papillary epithelial neoplasm. Often is calcified, maybe 30%. Cystic and solid. MCN's occasionally calcified, but then more cystic. And neuroendocrine is typically more vascular. And this indeed was a SPEN tumor. Just a terrific example. In this case, I asked, what's the most likely diagnosis? Well, there's a large cystic lesion left upper quadrant toward the left mid-abdomen. And I guess the first question you can ask is, could this be adrenal? Could this be gastric? Could this be retroperitoneum? Could this be splenic? Yes, those are all possibilities. And I gave you a few choices. I put down adrenal carcinoma. Adrenal carcinomas can be cystic, but not this cystic. Usually they're solid. And GIST tumors become cystic when they're treated, but not this cystic. And Serocystenomas is indeed a good possibility. But what I like here is there's a solid component at about 3 o'clock, and there's septations. Remember, when you think about mucinous cystic neoplasm, it has ovarian stroma, and that's why you have septations. The solid component ended up being high-grade dysplasia with an mucinous cystic neoplasm, or MCN. Just a wonderful, wonderful example. In this case, the patient's primary diagnosis is, now, one thing you can see is the patient has cirrhosis and a big spleen. But then you look at the pancreas, and the patient's pancreas is replaced by fat. But it's diffuse fat, and you can see the mass effect of where the gland was, or the gland still is, but it's replaced by fat. When you're diabetic, you can have fatty infiltration of the pancreas, but not this really prominent fat. And this is the classic hallmark appearance of cystic fibrosis. Beautiful example of cystic fibrosis and secondary cirrhosis due to the cystic fibrosis. Just a wonderful example. The most likely diagnosis in this case is, you look at a very vascular lesion, the liver is not cirrhotic. And you could think about FNH, you could think about hepatic adenoma, hemangioma, nah. Hemangiomas get flash filling when they're small, but this is too large, and very bright arterial with what looks like a pseudocapsule. You look at the venous phase, the lesion washes out, but you see the mass boundaries, and you see some solid and cystic components. Again, not a hemangioma, and really not good for an FNH because they're more homogeneous. I think you're stuck here between hepatic adenoma and hepatoma. The capsule, to me, is more hepatoma, and indeed this was a hepatoma. I will say, or at least I'll mumble when I say, that hepatic adenoma is a possibility, but hepatic adenoma is considered a premalignant condition and will be resected either way. So this indeed was a hepatoma. This patient has hematuria, and I'm asking what's the best diagnosis. You see at first what looks like a very vascular process in the upper pole of the right kidney. And then you realize that's what it is because you can see it on the venous phase, but it washes out. It's not a stone, it's not a tumor, and it's not neovascularity. Now, it'd be great to have other images. So it's not a renal cell, and it's obviously not a stone because it changes density. It's not a transitional cell, but this is a classic appearance of an AV fistula. AV fistulas can be due to trauma, can be due to prior procedures, can be congenital, can cause hematuria and simulate a tumor. Just a very, very nice example. In this case, I say, what's the differential diagnosis and what does it include except for? Well, here you see a large cystic and solid mass, and you're trying to figure out where is it. Is it coming from the pancreas? Is it coming from the duodenum, the retroperitoneum? Is it the mesentery? Where exactly is this thing and what is it? It's large, it's not obstructing, but it's displacing. So when you look at it, a GIST tumor is a possibility. Duodenal GIST can be very large. Lymphoma, I don't really like it, but lymphomas can be solid masses, but usually it's multiple masses, multiple nodes. But I guess it's a possibility. This, in fact, was a desmoid tumor. That would be a good possibility. A lymphangioma would be another thought, but a desmoid tumor is a good solid mass. What this is not is a liposarcoma. Yes, you'll say some liposarcomas have minimal fat or no fat. This has no fat. Liposarcomas are less well-defined and more infiltrating. This was a desmoid tumor, but the least likely diagnosis is a liposarcoma. This patient had mediastinal whining, and I ask, what's the best diagnosis? Well, you see a mass in the AP window on the axial images that's vascular, and you see it very nicely filling in the AP window on the cinematic rendering. What are vascular masses? Well, it could be METs. Metastatic renal cell carcinoma can give you vascular nodes. You could have Castleman's disease that gives you vascular nodes. It's not an aortic aneurysm. Melanoma, the nodes usually aren't that vascular in the mediastinum. This is not a location for thymoma, but you can consider a thymus or thymoma in any mediastinal mass, or at least consider it. Maybe it grows there. But this is a great location for a paraganglioma. It's an uncommon mass, but vascular wherever they are in the peripancreatic region, in the adrenal bed, at the organ of Zerker-Condel. Beautiful example of a paraganglioma in the AP window. Classic chest location. In this case, I ask the question, what's the least likely diagnosis? Now, we see a cystic lesion that's off the tail of the pancreas. Well, Serocystenomas, it could be. It could also be a MCN. It could be a IPMN. But you also need to consider lesions that are exophytic to pancreas, lymphoepithelial cyst. That's a great possibility. Now, I asked what's the least likely diagnosis. I have neuroendocrine tumors here. Neuroendocrine tumors are typically vascular. They can be cystic, but when they're cystic, the rim is vascular. Here, there's nothing vascular. This, in fact, was a lymphoepithelial cyst, but it could have been an MCN, and it could have been a SPEN tumor. Sometimes SPEN tumors are all cystic and have no solid component. But the least likely diagnosis was a neuroendocrine tumor. In this case, what's the best diagnosis? You look at the heart, on the non-contrast scans, there's some funny calcifications, And then on the flash acquisition with gating, you see a large left ventricle and thinning of the left ventricle wall, and you see how it's outpouching. And the calcifications that we described are in the wall of this process. So what are you dealing with? This is not an angiosarcoma. Angiosarcomas are tumors that grow in, most commonly from the right side of the heart. It's not an aortic dissection, and I don't see thinning of the myocardial wall. Well, I do see thinning because of this large left ventricular aneurysm, but I don't see an acute infarct. And so we're dealing with a large ventricular aneurysm. Just a beautiful, beautiful example, very nicely shown. Look at the thinning of the left ventricle. Look at the outpouching. Look at the calcification. It's a great call if you can make it on the non-contrast scans, but just wonderful on the contrast-enhanced study. Now in this case, I ask, what's the likely diagnosis? Well, you look, there's something involving the lower esophagus. So you could think about hiatal hernia. You could think about a soft tissue mass there. So what occurs in the esophagus? You could have lymphoma, though it's pretty rare. Maybe it's nodes in the periesophageal region. You could have GIST tumors of the esophagus. Those are soft tissue masses. You can have GIST anywhere in the GI tract, from stomach to esophagus to small bowel to large bowel to rectum. It could be esophageal cancer. It looks like a mass involving the esophagus. The one thing it shouldn't be is a carcinoid tumor, because carcinoids are vascular. This lesion is not vascular. So I'm thinking carcinoid's the wrong answer. This ended up being a GIST tumor of the esophagus. A very unusual case, but soft tissue mass, you got to think about adenocarcinoma, you got to think about GIST tumor, or some other possibilities. So with that, I've given you 10 absolutely terrific cases. That's 10 cases to end the year, 120 quiz cases for the year, and soon, within weeks, we're going to have the new app on the Apple Store, which will give you those 60 new cases added to the hundreds we've had previously, and a whole lot of new files. And with that, I wish you a great day.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctss.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.